We'll move on to the next speaker, Dr. Anand Ambali. He is with us. Welcome, Dr. Anand Ambali. I am glad to introduce you to this August gathering. Dr. Anand Ambali, Professor Geriatric Clinic, has been organizing awareness talks on elder abuse for medical, nursing, and pharmacy students, senior citizens, and police personnel since 2008. He has 2 research projects and 5 publications on elder abuse. He is also a recipient of State Award 2016 from Government of Karnataka. I hope it is Karnataka Rajyotsav Prashasti for Best Geriatric Services. Fellow of Indian College of Physicians, Geriatric Society of India, Royal College of Physicians, Edinburgh, and Scholar of Commonwealth Commission, UK, for MSc Dementia from University of Stirling, Scotland, has 75 publications and 3 fellowships to his credit. He is on editorial board of various journals and has authored 2 books as co-editor and associate editor. Member of Vijayapura district in Karnataka, the Committee for Prevention of Elder Abuse, and he has organized various talks and awareness programs, organized several health checkup camps also as far as elderly senior citizens are concerned. Welcome, Dr. Anand Ambali. Nice to see you, and it's over to you.
A very good afternoon to you all, madam. Yeah, am I audible? Okay. Yeah. So I bring greetings to you from the. Am I audible?
Yes, you are.
Yeah. I bring greetings to you from the Geriatric Clinic. We started way back in 2007, this service to the older people. Then we started a dementia clinic, and we have a special immunization clinic exclusively for older people at our hospital. And we have already adopted a village wherein we provide healthcare services at their doorsteps. And of course, we also provide home health services for the older people. So today, I will be sharing some of the perspectives of the physician regarding elder abuse and what all the lessons I have learned out of them. And let me be frank with you all today that as a physician, I was not aware about what elder abuse meant. Then when I completed my course in the geriatric medicine, then I started knowing what exactly elder abuse looks like and feels like. And then I started reading. I made some friends from gerontology prospects, and then I came to know about details about elder abuse. And it took me around 1 to 1.5 years to understand what elder abuse. Then I started putting it in my clinical practice, and that is what I am going to share. In next 15 minutes, I will be sharing what cases that I have come across in my clinical scenario, what our geriatric clinic is doing in creating awareness about abuse, what research we are doing and in the future plans, and what recommendations we can give to the institutes and senior citizens. So all these experiences are the first-hand experiences that I'm going to share with all of you regarding how we came across the cases and how we solved for them. We had a 78-year-old man who had a known case of hypertension, and he presented to us with breathlessness. He was already on the 7 drugs when he came to us. Despite that, there was no relief, and symptoms kept worsening. That is how he came to our geriatric clinic. On examination, we found he has anemia and significant weight loss. Somehow we were not convinced, and we started digging him anything else you want to share. It took 3 to 4 visits in 3 to 4 months duration that he has to reveal what exactly happened to him. So we came to know from him that his property was sold and his children didn't pay even the penny from the money that they got, because of which he had a psychological trauma, and he has a financial being neglected, and of course he was neglected even for the food that he was supposed to be served. So our diagnosis as a clinician was he was suffering from hypertension, heart failure, anemia, and abuse. So the 2 important impact were there on him was anemia. That was because of the neglect, that he didn't get proper food even in his home. So I took the help of the psychiatrist in our team, and we initiated counseling on him, and it took at least 3 months for him to come out of that. And again, he came to the terms that he has to live, and he has to live independently with all the good emotions. So what we realized that after 6 months of his counseling and all, instead of 7 drugs, he came to only 4 drugs, and with that also he was living independently. So this is a case which for a clinician was challenging to identify, and unless he opened up, we could not have identified what was the cause for his symptoms not being relieved despite taking so many drugs. And anemia and weight loss was the symptoms that hinted me that this old man may be a victim of abuse. So that's how we went ahead and dig the history. This is a very interesting case. We had a patient with presenting with hypoglycemia, repeated hypoglycemia. 68 years old widow. She was living with diabetes, hypertension, and stroke. She was a regular follow-up to our geriatric clinic. She was admitted on emergency department at 1 a.m. Following hypoglycemia, for which it was treated, and she was sent back home the next day morning. After 1 month, again, she had a similar episode, again at 1 a.m. Again, she was brought an ambulance, and she was treated, and she was sent home. I think it's a simple case of hypoglycemia. Third time, when she was admitted after 4 months of the last episode, we found that she was having bed sores. And again, the hypoglycemia occurred at the 1 a.m. and same thing, the whole children's came and all that they made it. And this time there was a delay in recovery, and we noticed that she had a bed sores. Then the next day, this time her sister came to take care of her, knowing that she is bedridden, and then she revealed why exactly this case was happening at 1 a.m. So the daughter-in-law was not providing the food regularly for this lady, and this lady used to take tablets for diabetes, and she used to wait that the daughter-in-law get the food. But those days she didn't get the food, and she went to the sleep without having food, and that is how she developed hypoglycemia at around 1 a.m. And why 1 a.m.? Because her son, who is alcohol dependent, he used to reach home at 1 a.m. And the moment he saw that in that entrance the room, that mother is screaming and shouting, and she had a virulent behavior, and he used to call an ambulance, and she used to brought to the hospital. So these are the reasons why this lady, why we suspected and diagnosed abuse in her, was because of the bed sores. Despite she was active, moving around, her ADO was good, she developed bed sores. She was neglected, frequent episodes of hypoglycemia, because she was not provided, she was neglected food that she required, and she was neglected by her own family members, and being her son being alcohol dependent also had led to many social and financial issues in their home. So later, after a few months, she succumbed to the bed sores infection and all in the home. So that is a different story, but this is how this old lady has been a victim of abuse, and they presented to us. The third important case scenario I just want to present was, I just titled her as a mother from a millionaire family, because she came from a very rich family of a place, and she was admitted for having cough, fever, and we made a diagnosis of pulmonary tuberculosis on the day 1 itself, the day she was admitted. And after examination, we started her on tuberculosis treatment, and she started improving over the period of a week. And what was important to note here was, despite having symptoms for 1.5 months, she was not consulted any clinicians. So that hinted somewhere to our mind that there is something wrong with this lady. Why it took 1.5 months to get a lady in our own place to our medical college hospital, which is not very far. On the day of discharge, we went and told that, madam, you are now fine and you can go home. And she developed new symptoms. So no, I got a pain abdomen today, I don't want to go. Then again, we thought, okay, it's fine. Then after 3 days, again, we told her that we are going to discharge you, you can go home. And she said that, no, I got a headache today, I don't want to go home. So this is what again hinted to us that why this lady don't want to go home. She is avoiding to go home. That was a sign that was indicating that she's a victim of abuse. She doesn't want to go home. So what I thought was, by the time she was there with us for almost 18 to 20 days in the hospital, and I just told my intern and the nursing staff working there, who had become already close friends to her, just to try to dig out what is the issue, why she doesn't want to go home, what is the problem in her home. So what we came to know was she was not willing to go home because she was very happy here with the hospital, because she had a good friends, she has a new friends, she has a TV, and she used to get food on time. Her son used to get a food from a very beautiful hotel, very delicious food she used to get, and she can watch TV anytime, any serial, and she can take a nap. So there was no restriction at all. She was living the way she wanted to live, in a one in a room with attached bathroom, hospital room, you can think of, and that is where she didn't want to go. She said, all things that I can do here, I am not able to do in my home. I am restricted doing all these things, so I don't want to go home. So the message here is, what we see as a clinician in the victims of abuse is they don't want to go home early. They want to stay in the hospital because they again have to go back to the environment where there is an abuse. Okay, so all these three case scenarios which I have presented were challenges for us. Initially, in the first set, we could not able to make a diagnosis. Second, yes, the older person has to open up and have a confidence in us that this person is may solve my issues. I am not going to their home and solve the core issue, but the ill effects of abuse on the older people, at least we can help them to overcome and we solve. Now, with these intentions, what we thought was, we proposed from our geriatric clinic that the elder abuse should be considered as comorbid condition. Because why we proposed this? Because looking at the website of the Center of Disease Control, nowhere elder abuse is mentioned. Nowhere elder abuse is mentioned, because it is still considered a social problem. Here at we Geriatric Clinic, we have been highlighting that it is a medico-social problem. It is not only social problem. And second, it should be considered as a comorbid condition because it affects health too. So I endorsed this way back in 2014 at an international seminar, and re-endorsed through this conference to all the August audience here. And I also already started mentioning the diagnosed comorbid condition as abuse on most of the OPD slips. So here we had an old man, 75, who was under depression because of, again, being financially abused. So they're writing a diagnosis of depression and abuse. I started this concept here so that all clinicians be aware why he is under depression and what extra care should be provided to this gentleman who comes. So again, as all of us, we were discussing regarding the COVID instances. Yes, one good practice what we were having. I'll just show, because there were instances across India where their older people are admitted and left alone. They were not allowed to meet the people, and the relatives didn't know what exactly has happened with them. But in our institute, our administrators, they took the decision that all the senior citizen patients who are admitted, they should be allowed to meet their relatives, and even they can have food from their own home. So this prevented a lot of anguish among the older people, and most older people were at least happy that their children are coming and meeting him, or at least he's getting the food from his home. And second thing regarding abuse, what we have seen in our practice was, especially in the first wave, was the older people used to come to the non-COVID wards because we used to run geriatric services for the non-COVID people also. There they used to come and say, admit me in the hospital. Please admit me in the hospital. I don't want to stay in my home. So that was the fear and agitation that they had. Sir, I am living with the environment of abuse for last 24 every day, but 24/7. Earlier, my children used to go for the work and I used to feel happy. I used to do whatever I want. But now grandchildren, children, myself, everybody is staying in the home. It is creating nuisance to me. I want to stay in the hospital. Please admit in my hospital. This was how the few people came to our hospital to admit in general ward, because we provide free stay and free food for the older people. So coming back to the how we didn't wait for medical profession to know. We also brought the older people, senior citizens, that we tried to create awareness about what elder abuse means and what are the types. So what are your rights? So we started way back in 2008. The first activity which I conducted in whole of the Karnataka in 2008 was Elder Abuse Awareness Day through my institute, and continuously thereafter we are organizing Awareness Day for senior citizens, for medical students, for police personnel, for nursing college students, and we also empower them to know what are the rules and regulations, what are the laws governing them. So, and we also have a healthy discussion from the question. We take huge number of questions from the senior citizens and try to answer with the help of panelists that we have on the board. So this is what activities we are doing to empower the older people, what they should know. And the other important thing what we are doing is creating an intergenerational bonding. So for last 2 years, we are doing this program, connecting the younger generation with the older people. And you can see these are the whole list of medical college students where we taught them how to behave with the older people and bonding to be developed. And this is a place, especially in the mud, where youngsters and older people are sitting together, and we are sharing their problems with each other, and they can take the opinion of either of them. So these programs of intergenerational bonding are to some extent helping the younger generation to know what the older people wants and what they mean to us. And at our geriatric clinic, we also have developed a tool to identify abuse. So most of the screening tools available are questionnaires that we have to ask to the older persons. This tool is one which is an observational tool. It, of course, it requires 2 to 3 clinical settings before completing the questionnaire. And here we don't ask any questions to the older people. We just observe what are the findings he is having and put the tick mark. And it also helps to know the type of abuse. And the score more than 5 of this will help to suggest a victim of abuse. So this questionnaire or tool was also published in various journals and presented at International Federation of Aging, again with the kind help of Dr. Gangadharan sir, who allowed me to this. This tool is yet to be validated, but we are using at our clinic with the help of our interns and postgraduate students. So the one more try to know how the older people are abused and all. We did this study wherein we first taught them what is elder abuse and all, created awareness. Then we took the questionnaire. Out of 133 elderly who were educated, 13% reported elder abuse, and financial abuse was very common. And who abused them most? Again, the son. Their son abused us most. So again, we came across people attempting suicide because of the ill effects of elder abuse. So one of my study, clinical study of attempted suicide, we found that 7 older people were admitted because they were fed up being abused and they attempted suicide, attempted life. So this was a 5-year prospective study that we did and published recently. So what we have understood is we have to talk to caregivers, and we should also listen to them. What are their perspectives before labeling that he is a victim of abuse? And adjustment disorders are common, and burnout in caregivers has to be addressed by the clinicians. So what is the role of institute? Actually, it's an ideal place for victims of abuse because we have a team of geriatricians, psychiatrists, psychologists to support them. And we also provide food and the medicines to them so that they can feel it's comfortable and safe. And this becomes a respite for a caregiver. This is very important concept that we have bothered, wherein older people, caregivers, they feel that if the old man is staying in the hospital for a few days, they feel comfortable in the home for those things, and those undone things they can do, and the caregiver can relax for a few days. So what I learned to wrap up over the decade of services to the older people and identifying abuse. So elder abuse is a medical social issue. It should be considered as a comorbid condition. So it is definitely affecting the health of the older people. And older people with pension are better taken care than, he may be very rich, but that doesn't matter. What I have felt in my clinical practice is if the older person is getting a pension, old lady is getting pension, she is better taken care in the home. And clinicians must be aware of the red flags. That is what we are doing as a Vice President of Geriatric Society of India. We are creating awareness about elder abuse among the clinicians. And of course, I have seen counseling and teamwork works in this situation, but it takes time. And handling victims of abuse is not so easy. It needs a lot of patience and it requires experience. So any physician coming out will not be able to identify this, I can assure. And providing respite care for the caregiver is very, very important, because they are burnout. And if they get the respite care, again, they will refresh and they may avoid abusing the older people. And it is always important to understand the views of both the victim as well as the abuser before we conclude something in that patient. So with these views, I convey my sincere thanks to Dr. K. Gangadharan sir, Heritage Foundation, for giving me this privileged opportunity, and Department of Social Work, Social Science, Central University of Kerala, and Madras School of Social Work. Thank you all for patience hearing.
Thank you, sir. Thank you, Dr. Ambali. It was a very active presentation, because you have presented a lot of case studies. So from the case studies, it is very much evident that the problems of elderly are having multiple factors responsible for the problems of elderly. Maybe you also have mentioned about the perspective of the caregivers. Sometimes we also need to understand their perspective. They might be burnout. There are cases where even some of the elderly uses some abusive words even for the caregivers. So that perspective is also very, very important. So thank you very much. One more thing, along with the medication, you have identified the need for counseling for the elderly. So I'm very happy that because I am being a person from social work background, we feel very happy when especially the medical practitioners identify the role of a psychologist and counselors. Thank you very much.